Okay, when you're ready.
Okay. Oh, wait. Okay. Gonna start broadcasting now.
Okay. Okay. All right. Good morning, everyone, and welcome to the Masterclass for Physicians. My name is Robin Young, and I'm the publisher of Orthopedics This Week. I'll be today's moderator. Each of our faculty members will be giving a 10-minute overview of their subject matter, and then after all the talks are completed, we'll be holding a Q&A session, and you can ask whatever questions you have. We have about 260 participants registered for our virtual classroom today, so one important piece of administrative housekeeping that we need to get out of the way is how to ask a question. Please write your questions in the chat section of the Zoom app and be sure to indicate to whom you are directing your question. Our masterclass is being sponsored by Flexion Therapeutics. This is the Boston-based producer of an extended release corticosteroid named Zilretta and is organized by MedTech Momentum, the premier life sciences marketing firm, and of course, Orthopedics This Week, the largest circulation publication in orthopedics. I want to begin our class today with some news that came out earlier this week. Johnson & Johnson released its forecast for orthopedic procedure volumes in the United States and globally. Their forecast based on feedback they've received not only from physicians in the US, but also in China and throughout Europe. They are, of course, the largest medical company in the world, and this forecast, I think, is the best intelligence I've seen to date on where procedures are going. Now, to quote Bob Dylan, you don't have to be a weatherman to tell which way the weather is blowing. We know the period we're going through right now is brutal. The reason we're holding this master class, frankly, is to provide you, the physician, with strategies to continue serving your patients, particularly when they have to go through these periods where their treatment plans are being delayed, and at the same time getting paid something. What J&J provided was an all business roadmap for the next few months. And for this current quarter, which ends in June, J&J is saying that up to 90% of orthopedic procedures and up to 95% of spine procedures are deferrable. And of those, 60 to 85% will actually be deferred. No way to sugarcoat it. It's a rough quarter, very tough to go through. For July, August, and September, things start opening up. J&J is saying that procedure volumes start to recover and that orthopedic procedures, including spine, will be, and it's a big range, will be between 20% below normal and in worst case scenario, 60% below normal. What they're saying is that by and large through that quarter, you'll be about 50% of your normal volume and you'll be rising through the quarter. Finally, in the October, November, December quarter, J&J is saying that orthopedic procedures, including spine, will be either at normal levels or as much as 15% above normal. They are, and I think every other analyst I've looked at is saying the fourth quarter this year is going to be very busy for everybody. When this is all over, I think we can all agree, and I don't think I'm overstating things to say that our businesses will have changed in some manner. So to kick things off, I do have a question for our audience right now, and we're going to be doing polling through through our meeting today. So the first question I have is, by how much have your patient volumes declined because of the COVID-19 restrictions? So please check on the answer that best fits your experience. We'll be sharing the results of the poll at the end of our presentations and just before the Q&A period. So to get into our program, I've designed a program here today that is meant to help us keep our heads above water during these next few months. And I've tapped 6 talented, resourceful physicians, 2 very interesting CEOs, and 1 reimbursement expert to talk with us about treating those patients whose arthroplasty or other surgeries have been delayed, give us some communication and financial survival strategies, which we can all employ right now. Our first of 3 physician speakers is Scott Sigmund. He's a team physician and a member of the Orthopedic Surgical Associates and Chief Medical Officer at Orthopedic Laser Centers, and lately an increasingly popular podcaster. Scott?
Oh, thanks, Robin. I really appreciate the opportunity to be here again. So yeah, as you said, one of my latest endeavors that's keeping me busy here in my master bedroom closet is I am the host of the Ortho Show podcast. And it's really fascinating to me, expert after expert after expert that I interview are all really messaging very similar things. And that is the way in which we practice medicine when we get through this pandemic is not going to be the same, and it won't be the same probably forever. So the idea of, as we emerge, and you talk about those J&J numbers, which are very encouraging as we go into the fourth quarter. So let's ask, how are we going to see all those patients? So are we going to have a waiting room filled with 75 people, which is where we are in my practice of 10 doctors? That ain't going to happen. Social distancing is here to stay. So are patients going to take 3 hours out of their day to come and get healthcare from a physician? Hey, maybe not. Maybe you'll be able to sit at home and be able to have that conversation and not take so much time out of your busy schedule. The bottom line is, Robin, is that we need a plan. So we've got, maybe 2, 3, 4 more weeks before we start reopening and starting to see these patients. And I urge all of you orthopedic surgeons out there in practice, whether in a hospital setting, academics, or whether it's in private practice, you should be organizing right now your thoughts and your energy as to how you're going to get through this with a discrete plan. So in our practice, we just named a new CEO of our practice yesterday. That is not a chief executive officer. That is a chief emerging officer. And we're going to put together a subcommittee within our practice that's going to look at the various options that are available, because we're still going to want to provide high quality, efficient care, but we're going to have to change the model and how it's delivered. So what are we going to do? So we interviewed a great Dr. Mike Greiwe from Ortho Live, which is one of the only HIPAA compliant telemedicine programs that's out there. So HIPAA's gone now, but I can tell you HIPAA's coming back. So you're going to need to have a HIPAA compliant telemedicine platform. You should start looking into that and thinking about that. Physical therapy is going to also change in the way we go forwards. We had a great physical therapy group on last program, but we also interviewed Dave Nichols, who's the CEO of AMP Recover, which is a physical therapy platform that's going to allow you to provide HIPAA compliant telemedicine so that your patients are going to get even better care. You'll have better tracking of your outcomes, and you'll be able to still now, most importantly for the physicians and physical therapists out there, be able to charge for your time. So those are the types of things that we're looking for. And I, as a physician, as I'm thinking about how am I going to treat my patients with osteoarthritis, knee pain in particular, well, we're going to do telemedicine, right? I don't need a 70-year-old woman sitting in my waiting room with somebody sneezing and passing virus. Stay home. Let's talk. Let's figure this out. We can diagnose, what's going on, especially the patients where we've had previous x-rays, and let's have a plan. And so what I'm looking for in the plan when the patient comes to the office is to really have something that's highly efficient, that's timely, that's durable, that's going to provide this patient to come in, get pain relief for a predictable period of time. And that's why Zilretta right now is my go-to choice for the treatment of osteoarthritis knee pain. So it's a novel intra-articular injection of cortisone that provides up to 70% of patients are having significant pain relief out to 3 months. So that durability, that predictable action is something that for me is something that's very valuable for my patients. Now, I'm using other modalities still to treat osteoarthritis knee pain. One of my other favorites is Waiver, which is a medical device that creates a temporary axonomesis to the nerves. And that can provide significant pain relief for outwards of 3 to 6 months as well. The only issue with the Waiver right now is it does require about a 45-minute session with the patient. And many of our patients are hesitant in the setting of the pandemic at this time to have that long of patient contact. But we have had success with that, and we will use that going forwards as well. You noted at the start of the broadcast also that I'm the Chief Medical Officer of Ortho Laser. We've had great success treating patients with laser treatment for osteoarthritis knee pain. The problem is we're in an unprecedented time of unemployment. People don't have a lot of extra cash. So laser is a modality that's a patient pay modality. Most patients are willing to pay to be able to continue, but at the moment right now, they're home, they're saving their money, and they're waiting for that paycheck to come so they can get out. I can also tell you, I'm not getting a lot of phone calls for patients that are looking for PRP or stem cells at this time, which is regenerative medicine. That's also something that's on the back shelf. So to summarize, my opinion is at this point, we need to really be focused on a plan to move forwards. Now is the time to do that. There are some great options that are available for you. Yes, I'm using Zilretta as my go-to treatment for osteoarthritis knee pain in the setting of this global pandemic. Really thank you for the opportunity, Rob.
Oh, that's terrific. That's outstanding, and you're absolutely right. This is exactly the time to plan because the life is going to be different once this is done. Our next physician speaker is Grant Zarzor. He's a board certified total joint specialist, and he is president of the board early in the morning out here in Oregon, president of the board for the Alabama Orthopedic Clinic in Mobile. Grant.
Thanks, Robin. Nice to be with you all today, and greetings from South Alabama and Mobile, and happy to talk to you a little bit about what are some of these strategies we can do while some of my patients are now currently languishing at home waiting for their elective procedure, where it was elective a few weeks ago, and then as this time keeps going on and on, it's getting closer to urgent because patients are stuck in their chair, they're stuck in their house. You've got to worry about immobility issues. And I think all of us can relate right now with COVID that it seems our refrigerator door is much closer than it used to be. And there's too many things in there that we are being enticed by. And so, weight is becoming an issue. So I do want to give a little background. I do about 5,500 clinic visits a year and about 450 joint replacements a year, just for everybody to understand. I'm kind of a middle volume guy. I do partial knee, totally up. And I am a consultant with Flexion as well. And so there are a number of interventions that I'm using right now, and I'm almost all telemedicine right now. As Scott mentioned, it's become very quickly a big part of my practice, and it's a way to continue to engage my patients and discuss some new treatment options and continuing others. So specifically, some things I'm doing. As mentioned, weight loss is the first conversation. In South Alabama, we do have a few that are overweight. And I find that all too often they don't have a specific strategy. I've got a one-pager on a diet that I like that I hand to them. And a lot of times my telemedicine and clinic visits are feeling more and more like primary care visits, but it's important for them to be able to be candidates for surgery when this lifts. I mean, the last thing we want is elective surgeries are back on and they're coming back in for setting up their surgery, and all of a sudden they have a comorbidity that hasn't been managed properly during this time, and now we got a further delay that's not related to COVID anymore. So weight loss, smoking cessation obviously is a longer conversation. Anti-inflammatories, medicines are going to be included. Home exercise programs, I'm emailing exercises right now, but I'll tell you, I'm real excited, as Scott just mentioned, about virtual therapy. I think that a lot of us need some interaction on the other side to make sure those exercises are being done correctly, instead of a one-pager and maybe a few different things at home to try to do it on your own. As I explained, you get the phone starts ringing and you put your piece of paper down. But if the virtual therapy has you engaged, I think that's a great tool. Diabetes is an issue across the country, but certainly not lost here as well. And, in order to have surgery, your A1C needs to be 8.0 or below. And, when we're talking about treatment options, the extended release injections that we have now, as mentioned, are great. And when you're talking about managing their diabetes, I've had people in the past with traditional injections, traditional corticosteroid injections, and I've now raised their A1C. They come back to clinic and go, I've been doing my diet. I took that dadgum piece of paper you gave me, and I've been following it. And how did my A1C go up? And so I don't want to be part of the problem. And so I'm real excited about, these extended release formulations that will maybe, it seem to be, by all the data, their glucose spike is less. The efficacy of treatment lasting 16 weeks, and I'm just not seeing any issues with side effects. So it's become a big part of my treatment plan for conservative treatment. Now, we're waiting 3 months after that injection to do surgery, and we want to make sure we're not risking anything on infections and keeping a hold of all the data. And lucky to have a very low infection rate below 0.5%, but we want to keep it that way, and so make sure that we're not contributing to any issues. So injections are fitting well, but this is also a great time for research. And Scott mentioned, I got journals that sit on my desk sometimes and aren't fully read. We need to be learning more about what the options are and what the data is that may be sitting in this journal next to me that I could be using to implement new strategies that I'm not currently doing. So I think that maybe diving into the data a little bit would help all of the surgeons out there to make sure we're all offering the most up-to-date things. So, I tell you, I really have had a great opportunity through telemedicine, engaging my patients who've been canceled from surgery. I'd highly recommend getting them on your schedule and talking to them and expressing to them, listen, here's the situation. We don't know when we'll be back to surgery, but when we are, here's our plan. And here's what we want to be doing right now in between. And so it's a great way to continue that engagement, to hope that some of that J&J number for next quarter is elevated as much as possible for me and for all the surgeons out there. It's to continue to engage those patients to know that we still care about you during this time. So kind of to summarize, I'm doing a whole host of things in the clinic, but 98% plus of my visits are virtual, still able to accomplish those things, and excited to when this thing is all past us.
Yeah, amen. I mean, all of us are gonna. Well, so we won't be able to pop the champagne because we have to go get to work, right?
Right.
Yeah. So that was terrific, Grant. Optimize the patient while you're at it. Why don't you optimize yourself? Catch up on the reading. That was terrific. Our next speaker is Randall Pate. He's a very active provider with the Oklahoma Joint Reconstruction Institute. Randall, you're up.
Thank you, Robin. I really appreciate the opportunity here to speak to everybody and hear what everybody has to say. A little bit about our practice here in Oklahoma. We have one surgeon, Paul Jacob, and three PAs. So we try to keep 2 PAs in clinic and him in the OR 5 days a week. So that's been great up until this pandemic. And we call it the pandemic +1 because Dr. Jacob was actually in Hawaii on vacation the week before we got shut down on elective cases. So we've got that also hanging over us here.
Excuse me, is he stuck in Hawaii?
No, he wishes he was stuck in Hawaii because he's stuck here not being able to operate, which is bad for all of us.
All right.
So he's back, and we fired up the telemedicine stuff here in the clinic. All the PAs are doing telemedicine. He's actually doing what Dr. Zauzar recommended and speaking to all the patients who've been postponed. We are a very high volume. We've done over 1,000 joint replacements the last 2 years, all with the Mako. So very active, which also means that we've had a chance to reschedule approximately 138 patients from surgery already. So we're trying to come up with strategies that we can treat these people who have been rescheduled with and try and figure out how we're going to go back about getting them back on the schedule. Interestingly enough, our governor yesterday said that we're able to begin elective surgery starting on April 24th, which is next Friday. So all you guys jealous of people that living in the flyover state right now, which usually doesn't happen. That's been a good thing, but we're having to strategize how we're even going to do that because we normally run 2 rooms with 2 gas and we're only going to get 1 room and 1 gas and trying to figure out the logistics of how to make all that happen. So it's going to be a slow trickle back. So we're trying to come up with strategies that we can do. What we decided to do initially was take all of our over 65 or according to the CDC at-risk patients and move them to July and try and get them in the schedule in July. And then we also decided to offer them injections as treatment option in the interim to hopefully allow them to increase their activities, allow them to get outside and walk so they're not stuck in their house in this time of social distancing. It's been interesting. We've had a pretty mixed response of people willing to come in and go through the injection, but the injections are pretty much all we're seeing in clinic right now is a face-to-face visit. I just had clinic this morning and did 6 injections on patients to hopefully help alleviate their pain and give them a chance to increase activity. We here for the last 2 years have been using the slow release steroid injection in clinic. I am a consultant for Flexion as well. We basically sit down with the patients. The PAs see all of the patients in clinic initially. The doc actually sees the H&Ps once they've decided to proceed with surgery. And we talk to them about their treatment options, about traditional steroid injection or a slow release steroid injection. We typically have a 3-month wait for our patients to have surgery anyways. And so about 2.5 years ago, my doc came to me and said that we were no longer going to provide viscous injections because he had lost more than 6 figures in 1 year doing the buy and bill. So I totally understood that, but I asked him, what can I do in the interim for a new patient that presents to our clinic? And I see him and they say, hey, that's great, you need a knee replacement, but our next available date's 4 months from now. So what can we do with physical therapy, with bracing, and what can we do to provide some relief? And so that's where we actually came up with using Zilretta. It's actually changed how I do my practice with traditional steroid injections. I used to have the patients follow up in 12 weeks. The first several injections that I did with the slow release steroid, they came back at 12 weeks and told me they still didn't have any pain. And I thought, well, I'm wasting your time and I'm wasting my time. So now patients that get the slow release injection, they actually follow up as needed and they let me know when their pain starts to return. So we've seen some great success with that, and just trying to, increase activities. Just like Alabama, we have a huge percentage of patients here that are obese. We have a huge percentage of patients here that are diabetic and don't even know it. It's not uncommon for us to screen for our A1C cutoff is actually 7.5. And we have people that come in over 10. And we've had patients tell us that their primary care doc told them they wouldn't be able to get below 10. So a lot of that's frustrating and trying to deal with that. But we are trying to optimize our patients while we're in this pandemic and see what we can do so that when we get ready to return to normal activity, whatever that looks like, we'll be ready. And that goes with, like Dr. Sigmund said too, about telemedicine. We're going to continue telemedicine visits, I believe, for at least our 3-week post-op visits and maybe additionally our 6-week post-op visits. The question is, we typically get an x-ray at 6 weeks. And so we'll have to figure out if we want to push that out to 4 months or what we're going to do with that. But we are going to have to try to mitigate how many people are in our lobby initially.
For sure. Okay, that was terrific. Thank you, Randall. That was an excellent presentation. So these times have really pushed all of us to consider new technologies, to engage with our patients, generate new sources of income from these remote patient treatments and interactions, and explore new ways to train and stay sharp, which is what our next set of speakers will be addressing. To help set the stage for our next set of speakers, I'd like to ask our audience the following question. And as you heard, everybody was talking about telemedicine. So how many of you have started using a telemedicine program? And if so, when? More than a year ago, last 60 days, not yet? Or is it not high on your priority list? Select your answer, click submit, and thank you for that. Our first speaker from our on the CEO side is Peter Ranger. He's the Chief Learning Officer with Fundamental VR, as in virtual reality. Earlier this year, AAOS, the largest orthopedic surgeon society in the world, selected Fundamental VR as their virtual reality training partner. So while we're optimizing our patients, perhaps we can optimize ourselves as well. Peter?
Hello, welcome. Thank you very much. I'm joining you from London. As we said, I'm the Chief Learning Officer for Fundamental Surgery, and I'm here really to try and talk about teaching, training of surgical residents and the possibilities for technology and how that can help, especially in the new world that we're facing and the real benefits and affordances that virtual reality and other technologies can really have. So what I'm going to do very briefly is just show you a very short video for those of you who aren't familiar with our product set. So bear with me, this is always where it goes slightly wrong. So let's have a look. Okay. And it's just to give you an idea about about our product, so we can have a little better idea for those of you who aren't that familiar. So it's a marketing video, but what you can see here is a virtual operating room where you can see a range of surgeons that are connecting from all over the world to look and discuss virtual surgery. So they can beam in from phones, from mobiles, or from virtual headsets, so wireless headsets in this way.
Wow.
So bear with me, I'll just stop sharing there. For the moment. So that hopefully is a very brief snapshot, but essentially you're wearing these kind of things, Oculus Quest or the more complicated things. You can enter into an immersive virtual environment. You can see the patient in front of you. If you're sitting there or standing there with a colleague from across the continent, like colleagues here, I'd be, love to be in a VR session for you to teach me more around, TKA, because we've got a TKA procedure and also total hip replacement as well. And we'd love to get more involvement and feedback on our simulations. And for me, my passion is really teaching and thinking about surgical residents. So, in theatre, hopefully you can imagine if I was sitting there, one of our esteemed colleagues were coaching me through surgery, you can imagine them using the kind of OODA framework: observe, orientate, decide, act. What are you going to do? Why are you doing it? Let's have a conversation about what might go wrong in this step. What are your preferences on this element? What's your surgical objective? What are you trying to do here? That whole real value of consultant surgeons who are really good teachers, who know how to ask questions, engage trainees in a safe space that can be done in a steady manner from across continents, and also students coming together, trainees asking themselves in groups, talking through cases and understanding the real elements of surgery in an environment where you can communicate, talk, look at the x-ray and really take people through your thinking process. Because in surgery I've often spent hours watching loads of videos, and I often try and get the surgeons who I'm working with to narrate and talk through, but obviously their first concern is the patient, so they're not always able to narrate what they're doing and thinking. But in a virtual environment, you can stop, you can pause, you can go back, you can really understand the benefits and the thinking around surgery. And I think this multimodal element, just like at this Zoom web conference, you can imagine 200 residents is being taken through the benefits of the injection that you were mentioning before, and describing how you administer that, where you do that, and what the basis of that is, how you localize the particular area you're doing. All those things are really important. And our, the benefit for surgical residents really is at home. They could be using this kit. They can go into their hospital and use the haptic VR system. So that's when you're using the haptic geo, so you get force feedback. It's amazing when we're working with residents, and you can run rongeur up and down the spine. You can use a sagittal saw. You can feel the reamer. One of the whole, I'll give you a good example I know from TK, total hip replacement, is trying to explain to residents the orientation of the reamer and that feel in the change of tone. And really in VR, you can kind of talk them through the whole orientation and the force feedback, but you can take people through the story of the procedure without that at home, in terms of learning the benefits up front. So there's an amazing potential to scale up and put surgical training in the hands of trainees, and add and do that in a way that really capitalizes on the value of the surgical teachers we've got to really engage with residents across the world. And I think there's amazing potential there in terms of assessment of knowledge and developing new areas, sharing practice. And I think technology in today's world is really showing us there's a real need for that, capitalizing on our downtime when we're not in surgery. How can we really engage our residents? And the last point really is that this is a new world, and we've been saying for ages that the youngest generation are coming through, and this is now in schools. So they're going to be expecting this new engagement and opportunity as well. And there are some added benefits. You can bring up enlarged 3D models in virtual reality. You can highlight stuff there. There are elements in a virtual world that we can have dynamic x-rays we've got going. We've got ultrasound. We've got all these things that really engage you that you can't necessarily do in theatre in a real time on a real patient. So, hopefully, this gives you a little bit of idea. The world is changing, and the technology is now getting there to enable good teachers to teach surgery and to enable residents to learn independently and in groups in a safe way that teaches safe surgical practice.
Well, thank you, Peter. No, and you're absolutely right. The other key lesson here is that these technologies they're only going to get better. They're only going to get faster, more realistic. It's now would be the time to engage with that. And also finally point out, you are the one selected by AAOS. So this is absolutely something every surgeon should be aware of and should be, making part of their training program. Our next speaker, I think, is going to be a revelation to all of you. He is the CEO of one of the fastest growing technology firms in the United States, in part because he is able to increase physician revenues, that's your revenues, through remote patient engagement. It is my pleasure to introduce John Pierce, up from the great state of Minnesota, from Zipnosis. John, you're on.
Thanks, Robin. I'm going to have you introduce me every morning to my family too, by the way. That was rousing. So a lot of talk about telemedicine. I thought I would just kind of share a little bit about what we're seeing and to give you context for our business. We license our virtual care technology to healthcare providers around the country, and that ranges from the big hospital systems to smaller independent practices, including surgical and orthopedic practices. The majority of the business is largely in primary care, although we've now got sort of the whole continuum of care, from sleep to travel medicine to post-surgical for bariatric, orthopedics, et cetera, et cetera. So it runs a big gamut of conditions that we're treating. So a couple data points that I'd share with you guys, and I think you're seeing this firsthand, and if I'm hearing sort of from each of you, we saw an almost 4,000% increase in utilization last month across the network. It's an absolutely astronomical number. And obviously it's been good for business for us, but I think it's also been a lot of pent-up demand, to be honest. And so what we're looking at then is, majority of that is COVID related, right? Those are patients that are coming to the health systems and using virtual care to be screened or treated for potential COVID. So we've been looking very closely at the non-COVID procedures that are going on. And I can tell you that for everything else, right, if you take all the upper respiratory conditions out, that volume has increased about 5-fold in and of itself. And I think what this means for the industry is, you guys are thinking about technology decisions, you're thinking about how real is it? Are these just little Band-Aids that you need to put out there? And then, Robin, I appreciate the data on, maybe by Q4, it's kind of business as usual. What we're seeing across the country, and I've been at the federal level, across the states, is that this is starting to become a lot more baked into just the regular practice. And a couple of things that I would share with you. The state regulations, from HIPAA, I think, Scott, you were mentioning that HIPAA will be back. Yeah, so if you're using sort of a Band-Aid solution, it's, these guys are either gonna have to upgrade their platforms or you're gonna need to move to something that is a little bit more industry grade. Although that's been very good in sort of helping this initial onslaught, the regulations have changed pretty dramatically across the state lines to open up. And honestly, it was probably 20 years regressive. And we've kind of fast forwarded it in about 4 weeks, a lot of the changes that should have happened. So I see it being really tricky at a state-by-state level for all of those to get rolled back, because COVID isn't going away. And just to give you that perspective, it's going to be here. You're going to need to maintain all these kind of things. So if there was a sharp cliff that we could all see, I think you would have a higher probability of those regulations moving back to where they were pre-COVID. But I don't see that. The other thing that's driving that is pretty aggressive reimbursement. So moving reimbursement for, especially in home care, Medicare, Medicaid, to have almost parity. I don't see parity lasting forever. I think that's a little bit temporary, but it went from over here for telemedicine to parity. I think you'll probably end up kind of back a little bit, where a lot of the virtual encounters will continue to be reimbursed. Probably not the same as an in-person clinic visit, but there'll certainly be better reimbursement for virtual, which gets into your world, which is a lot about orthopedics, bundle payments. How is this going to have an impact? And I think what we're seeing is that, first of all, there's two sort of primary use cases, and you guys have hit on those. One is, how are you just connecting with patients today? And that's just a vital necessity, either someone you're actively managing or potentially patients that you want to be able to connect with and just communicate. So that's certainly a starting point. We're seeing more sophisticated modes where as you start to pick up procedures again, how can you outsource or offload 1 or 2 follow-up visits post-surgery for active monitoring? And there's a lot of good data, and I think a lot of good evidence out there that well-managed patients, healthy patients, generally healthy patients, can effectively use virtual care for some of the simple follow-up. And you can do video, and if you do a Lockman's or range of motion, I mean, there's things you can do virtually that don't always need to be in place, especially for med management and the whatnot. So that's what we're seeing. Our systems, our network touches every American. We screened and treated about 1 million last month alone, which we don't have the name and cachet that a Teladoc or others do, but we did about 3 times the volume they did across our network. So we've got a really good perspective that's out there, and I'm trying to be as transparent as I can about sharing data, what we're seeing, what's working, what's not working, et cetera, because I think there's a lot of uncertainty about, is telemedicine viable? Can you use these platforms? Is it Zoom? I get it, it's still sort of early days, but I hope for this group, and certainly as you guys are considering the role of virtual care within your practice, know that there are very robust systems out there. You've heard a few, I don't know them, but I'm sure if they've been in market for a couple of years, they're HIPAA compliant and catered to you, they're gonna be just fine as you think about the short-term solution. But I'd really encourage you to think strongly about how you integrate this into practice, because I don't think we're gonna go back to the dark ages of where we were, even six weeks ago.
And probably the key question is, if you do integrate it in your practice, how can you maximize its revenue producing capabilities?
Yeah, there's a couple things. So we really focused around clinical efficiency. I think looking for solutions that make either offload work to non-surgeons, right? And how can you do some of the basic history collecting, medication management? What we do off of the Hypnosis platform is we basically outsource it to a really smart computer system. So you can take our average work time, by the way, is about 89 seconds across all of those visits. So we're really getting rid of that administrative burden on clinicians. So that means that your cost point is going down for anything you need to do virtually. And that's the first place you should start. How do you make it as efficient as possible? And then I think secondly, specific to orthopedics, I'd look at how you're leveraging virtual care within, if you're in a bundled payment environment, look at how you can maximize the revenue out of that. And there are some very clear pathways that are there. And then again, I think the reimbursement that you're seeing by adopting virtual or telemedicine is very, very positive for you guys. And if you're not facile with that, I would encourage you to look at how you can change some of your practice behavior to sort of leverage that efficiency, but still get paid effectively the same on some of these codes.
John, that is fantastic, and I encourage everyone to check out Hypnosis. It's a fascinating platform, and to your point, we do have probably the best reimbursement expert coming up next to address the exact point you were raising. And speaking about being paid, before I introduce Lauren Craig, who will provide us with an update on reimbursement strategies. I do have one more poll for you. When do you, our audience, think that this decline in elective procedures will stop and begin to recover? May, June, July? We need the poll. August or later? Select your answer and click submit. And again, just before the Q&A section, we will go over the results of all of our polls. Getting paid is what it's all about. Well, not all what it's about. It's an important part, though. Have been changing lately. The reimbursement codes have been changing, and to help us not only understand what is going on, but to take advantage of it, is Lauren Craig with MICRA. Lauren.
All right, can you hear me?
Yes.
All right, perfect. So I do have some slides because what would a reimbursement conversation be without a couple of codes and some payment values associated? So I'm going to attempt to share my screen right now and pull up some slides. So one sec. Let's see. Go here. Can you guys see that?
Yes. Yes.
Perfect. All right, so we'll go from the beginning. Is that good?
It's good.
We're driving? All right, perfect. So as we were discussing, telehealth is really kind of changing the landscape of how your orthopedic practices are moving forward. And I think if we think about and we take a step back and understand, what kind of occurred prior to the coronavirus, digital health and these types of services were already in existence, but the big barrier to kind of adoption and that market really growing was utilization by your patients, right? So you could prescribe these types of digital therapies, but getting your patients to actually use them and buy into the technology was difficult. Well, the coronavirus has presented this amazing opportunity where they're basically forced to not only engage with you via telehealth, but also these digital health platforms. So it's really presented a great opportunity for this sector in digital health, but then also for you guys to think about how you may end up changing some of the way you practiced prior to coronavirus. So one of the big things to know about kind of from a legislative standpoint about digital health and telemedicine and remote patient monitoring is this idea of the Waiver 1135 that was passed in March. So we're going to go through that a little bit. We're going to go through some of the codes and then the modifiers that are very important for you guys to attach to your claims. So to take a step back, for Medicare to cover telehealth, patients had to live in a rural area. They had to be an established patient, and you had to have had one face-to-face E&M visit with the provider in the last, I believe it was 3 years. And so, with this 1135 waiver, basically that landscape has totally changed. You can be a new patient. There are no restrictions from a, area that you live in, so anybody can receive telehealth. The other thing is what constitutes kind of that device that you're using. The HIPAA compliance has been taken away from a standpoint that FaceTime, Zoom, all of these platforms are being allowed right now. There are specific platforms that societies have really gotten behind as to kind of, which ones are providing the most benefit for their patients. So from an overall standpoint, Teladoc is certainly the one that's kind of the buzzword right now, but I would really encourage you guys as physicians to think about right now, what platform is really providing me the most benefit for my patients? And that's information that you can take back to your society and together really work together to come up with a platform that really works for your specific specialty. The other thing is, physicians can now provide telehealth services from their own home, obviously, right? We don't want patients to be congregating in the waiting rooms. And there are 2 actual place of service codes that are important for you guys to know. So the place of service 2 is the one that you would use on your claims to indicate that you had a telehealth service that, occurred at your home. And then you're also actually allowed to use place of service 11. So if you would have, performed that visit in your office, you can actually, indicate that would have occurred at your office as well. And even though you may be at home performing that, virtual visit, place of service 11 can be utilized as well. So I think one of the big things in that 1135 waiver that is very good for you guys to know is prior to this waiver, the E&M visits really could only be billed out and occur within your office. Obviously now with telehealth, the Medicare guidelines have included billing of the 992 series, which is really that established E&M visit that you would have used within your office. And I think the big thing here is that next year with the AMA and CPT, they were going to release new guidelines for E&M visits and kind of how you go from 1 to 2 to 3 to 4 to 5. Well, one big thing that was going to change in 2021 is this idea of time. And so, before it was kind of a long list of medical decision making, right? And kind of this puzzle game of like what constituted a 1 to a 2 to a 3 to a 4 to a 5. Well, 2021 said, you know what, we're going to look at the total amount of time that you spent with that patient, and then that's going to be a big factor in determining which visit gets a 1, 2, 3, 4, 5. So think about that as you are kind of engaging with your patients over a week's period of time. you may have chunks of time that you may have had with a patient during a day. Well, that time should be totaled out, and you could potentially be using those 992 series codes as well. So one other thing for you guys to know is the specific modifier to use when you're using telehealth services, and that modifier is 95. Now, Medicare has also released a bulletin that speaks to modifier GQ, so you want to make sure that you're consulting with your local MAC and your private pay coverage policies. There are some that have already been released for Aetna, Anthem, I believe, but you definitely want to kind of consult those policies as to which modifier would be most appropriate. I'm hearing that 95 is the modifier to go with. So again, those 992 series codes are very important. Obviously, also there are the telehealth services codes, remote patient monitoring codes. I think the big thing to remember with remote patient monitoring is there should be some type of vital or some type of physiological data that's being, interpreted from the device, potentially, that, would constitute the ability to bill out for a remote patient monitoring code. With RPM, the other great thing that was passed is the incident to billing concept, meaning that physicians are no longer the only ones that are able to bill out for these remote patient monitoring codes. And this really, allows you to kind of delegate some of those check-ins and checkups to your ancillary staff. So, I think one thing, if we take another step back, to think about, what does this mean for our clients, and what does this mean for kind of like for our landscape and the way that we do business? And, I think as the other panelists mentioned, telehealth is definitely here to stay. It will change the way that we practice over the back half of the year. And I encourage you guys to really think about kind of how you're incorporating it into your practice so that you can be a great advocate and be vocal with your society about how you want telehealth to be administered for your specialty. And this will actually relate back to payment, right? So other societies are already jumping on this telehealth bandwagon as well, and they're trying to advocate for better payment. And the more that you guys figure out kind of how this is going to be utilized most effectively, the bigger your voice can be back to your societies as well. So thank you so much.
Thank you so much. Wonderful. That was outstanding. So let me quickly summarize before we jump into the results from our polls. So Carolina will be organizing that, but summarize just briefly what we've been learning so far. I've been taking some notes. I think certainly Scott was very talking about the waiting rooms needing a plan for emerging from this deep freeze that we've had to go through in the end of the first quarter and through the second quarter. I love this idea of using this time to both optimize your patient, optimize yourself, use whatever time you've now got available to do some things that maybe you wouldn't have had time to do if you were busier, and certainly in the fourth quarter where you will definitely be very busy, be more difficult to do. Randall, I was really interested to hear that Oklahoma is going to come on stream a little bit quicker, and how you're thinking through. I didn't want to use the word triage, but maybe organize your patients so that you're more efficient as the patients start to come in. It's not going to come flowing in quickly. It's one operating room, not two. But I was fascinated with the way you're making these decisions and trying to figure out how to manage that flow as it comes in. And again, also not having a crowded waiting room again and so forth. I really believe this virtual training, start now. It's a real deal. It's going to be part of your life, and it's only going to get better, faster, cheaper, more impactful. And again, you've got AAOS is recommending it. It's the stamp of approval. And John, I wish we had more time with you. I suspect that the concept, you have 1 million patients, that you're growing 5,000%. There's something there you've got, and I think all practices should make themselves familiar with it and see if this isn't a tool that they can use. And I know that using your tool, it's also a revenue generating opportunity for a lot of physicians. And speaking of revenues, if I was listening carefully to Laura, and then I try to do that, got to be accurate. Look at that 95 modifier, that 992 series code. Tattoo it on your arm. It's important. Okay, Carolina. And again, all of these presenters today, you should have in your chat section ways to get back to them with more detailed discussions as you need to. And I will finally say, as you know, dealing with your patients to whom you have had to delay, you have a variety of strategies to work with, including advanced corticosteroid treatments, including other forms of managing their pain while they're getting ready. And by the way, I think two speakers, again, hit this point of optimization, help them with their diet, help them with diabetes, and so forth. Do we have the codes? Great. Wow. How much has your patient volume dropped? The vast majority, over about 70%, said more than 75%. That is brutal. That is brutal. Thank you. Next poll, Carolina. Carolina. When will this decline stabilize and begin to recover? June. June is the most common, June and July. I think all the best estimates we see point to that. And I think everyone agrees it'll be a rolling, it'll not all at once. Oklahoma might be first, but it'll blossom through the country and get ready for the fourth quarter. Okay, thank you. And the next one. In the last 60 days, how about that? People have started using telemedicine just recently, 72%. All right, that is terrific. I think that's the end of our polls. Looking at questions. Let's see, I'm going to scroll. Let's take a look at what we have here. Okay, just a minute. Okay, just a second. Sorry. Oh, we did have a question for Randall, and it looks like, Randall, you may have addressed it, but I think other people wanted to know, how has Mako improved your practice?
So it's interesting. We started with hips first, just to see the stress level of my surgeon go down. It was amazing just to know that he's putting the cup in where it needs to go. And then we switched to knees, and the original plan was to do 2 knees a week so we could advertise that we did robotic surgery. And then he did the first couple, and he was actually was a physical therapist before he went to med school. So I think his understanding of biomechanical chain is excellent. And when we saw tissue balance knees prior to going to the robot, you know, he was very happy with what he was getting. But going to the robot and seeing what precision you could get with that balancing using that technology, the results we have, it's not uncommon for patients to come back at 3 weeks and have 135 degrees of flexion. We're using less pain medicine post-operatively. So that's all good stuff. But you still do have to, it doesn't replace a surgeon, that's for sure. I mean,
Right.
The thought that goes into it and how much he moves, our surgery time's longer because he makes little micro movements and checks everything. And it's from a PA standpoint, sometimes that's frustrating because you just want to get to your part of the case. But I understand the importance of getting everything balanced correctly.
And I think you were saying that the surgeon felt a little bit more relaxed at the end of the case, that it took a little stress off his shoulders or her shoulders.
Absolutely.
Quick question for you, Scott. I do think this issue, I don't think COVID's going to just disappear. I think this issue of how are you going to manage so-called waiting rooms. Do you think you're going to go to a virtual waiting room, or are you going to have folks wait in their car and then when they get the buzz on their cell phone come in and out without seeing anybody? How are you going to manage that, do you think? Scott? Let's see.
All right, now I'm there. There you go.
Oh, there we go.
All right, good. So I think it's going to be multifaceted. I think there's going to be technology for sure, and I don't know what that technology is. And my chief emerging officer is going to be looking at all of that, and we're going to analyze it. I think we're going to move a lot of the appointments that are not necessarily needed for a true physical appointment to be done virtually with telemedicine. So we're going to reduce the number of patients. I want to be clear. I'm not going to stop seeing patients. I mean, the doctor-patient relationship requires, physical touch, especially within orthopedic surgery, to diagnose. So I think that all new patient appointments are going to be done face-to-face. But there's no reason for a 6-week total knee replacement follow-up to be done in person. You can do virtual evaluation of the range of motion and movement. You can get a sense of how they're feeling. And then obviously you can push those patients in if they are required to. So I don't think we're going to have people sitting in cars. I think we can do this smarter and better. But I do think it's going to require a lot of teamwork and a lot of time and energy to get it right.
Grant, how are you planning to handle patients when they start coming back?
Well, we already had an issue in our clinic before this started with kind of being overwhelmed with the number of patients, which is a good problem to have, but we're adding more supply. We're building another building, and we're going to have to continually evaluate how close people can come together and how the evolution of this virus occurs and what other treatment plans there are out there. And, I think you're going to see waiting rooms be reorganized. I don't think any doctor thought we'd be thinking about how our waiting room looked a few months ago, but now it's going to be discussed on a higher level on we better make sure it's organized to keep the patient safe as possible.
Well, not only, it'll be the patient who worries about this at least as much as you do. You absolutely want to deliver to the patient a comfortable, safe experience. But Grant, one more point. You talked about the diabetic patient and putting that extended release corticosteroid and somehow linking that to diabetes. What do you know about that? And can you give a brief expansion of what you were referring to there?
Well, I think that when you look at the data on comparing these extended release formulations like Zilretta and then you compare it to traditional corticosteroid, the glucose bump immediately after the injection and what lasts for days is different. Traditional steroid is just going to be more in the systemic circulation. It looks like it's 18 times higher when a traditional steroid is given compared to the extended release formulation. And so my goal is I want this injection in their knee joint and not anywhere else. I don't want it interacting with other organs or issues and having prolonged issues where they're driving home. I had a patient that really drove me toward using the extended release formulation because I did a traditional injection that she had had for years, but as she got up in age, she was 80 years old, she collapsed at the front desk after a traditional corticosteroid due to she couldn't handle anymore the hyperglycemia. And I went to the emergency room with her, and she got a liter bolus, and she did fine. But she did better than I did because it scarred me. And so it's really been a major player for me to really dive into the data and understand, every treatment we're doing and making sure that the first thing is we're not harming the patient, but every patient wants some sort of solution for their pain. And I think that this extended release formulation is a great compromise.
Wonderful, wonderful. Well, gentlemen, gentlewomen, this has been a wonderful meeting. I want to thank everybody, and most importantly, I want to thank our audience. Again, for more discussions with any one of these panelists, faculty members, I think we provided web addresses for each of them, so feel free to avail yourselves of their expertise. So thank you again. Another outstanding master class. Take care, everybody.
Thank you.